I'm one of the first-year EMIMs. I'm going to be talking about the evidence-based medicine approach to low back pain. So here are some things that I'll be discussing. Quickly, some cases, the diagnostic approach to thinking about low back pain, when and if we have to use imaging, and some of the treatment modalities and the evidence behind the treatment. So here we have some cases. We have a 65-year-old male with low back pain for 1 day, radiates down the leg, and it started suddenly while lifting. We have a similar case, past medical history of prostate cancer with gradually worsening low back pain, worse at night for the last 6 weeks. Another similar flavor of low back pain, but this patient now has osteoporosis, low back pain 1 day after a slip and fall. And we have another one with HIV, IV drug abuse, complaining of low back pain for 4 weeks, associated with fevers, decreased appetite, and she's causing a ruckus, asking for pain meds. So question for the audience, how are these patients different? And more importantly, will knowing more information change the management? Yeah, so they all have low back pain, but they're all a little bit of a different flavor, and they all could read more either scary or more less scary. So things that we want to for sure do is get a better history and physical. We want to characterize the pain onset, especially as a sudden versus gradual progression, and how it progresses over the course of the time. The quality of it, sharp or dull, is it worse at night and unremitting? Radiation is important because that can clue you in on some sort of impingement. Severity, although severity is more subjective, it can tell you a bit about how you're going to manage the pain acutely. And timing, again, worse at night, is it worse in the morning, and it gets better with exercise, and so forth. So the topic is going to be acute low back pain. And just to clarify some definitions, what I mean by acute low back pain is back pain less than 6 weeks of duration. This topic was interesting to me because it's bread and butter emergency medicine. Actually, 1 in every 5 ED complaints is for low back pain. And it's the leading cause of disability claims in the US. So just a quick review. This is what I mean the low back. I'm talking about the lumbar region. Typically, we think of like musculoskeletal, meaning we have the vertebrae, we have the spinal cord, associated nerves, we have discs, and the paraspinal muscles. But there's a lot of things in this area that it's important to remember. We have the aorta that runs along the vertebral bodies. We also have the urogenital tract, like the kidneys and the ureters. We have retroperitoneal organs, as well as parts of the colon and GI tract. So this is important to know when you're thinking of your diagnoses. It's not just musculoskeletal, but you have to make sure that the aorta is okay, the urogenital tract, etc. So one way to think about low back pain, it's to characterize it in 2 groups. You can have uncomplicated musculoskeletal pain, which is, the most straightforward. And then what you really want to rule out, or the big scary, is the compression syndromes. And what I mean by compression syndromes are the cord compression, cauda equina, conus medullaris. So for things like uncomplicated musculoskeletal pain, it'll be more focal tenderness, history of recent injury. Usually it will be delayed pain, paraspinal pain associated with stiffness, and a completely benign physical exam. Whereas the compression syndromes are more scary. This is going to be pain that radiates along a dermatomal pattern, or sensory changes along a dermatomal pattern. You'll see decreased reflexes. You could see pain that's worse with Valsalva, because Valsalva maneuver increases intrathecal pressure. So if you have a compression, you're going to have more pain when you Valsalva. And another way to think about it too is during duration. And while my lecture is just on less than 6 weeks, it's important to note that patients can come in with subacute pain, which is 6 to 12 weeks, or chronic pain, which is over 12 weeks. And these are a little bit of a different management. So what is really important in talking about low back pain is going to be getting a good history and physical. You can get pretty much everything that you need from a good history and physical. A good history is going to uncover things like risk factors, as well as red flags. And by red flags, I mean, is the patient having any urinary retention or incontinence? Are they having any fecal incontinence, any saddle anesthesia, or progressive motor deficits? All of these big scaries are something that makes you consider getting imaging and doing a more aggressive management. Things like malignancy, if they have a history of malignancy, you'll see like nighttime pain, unremitting pain, usually more than 6 weeks. In patients that have recent trauma, especially older patients with minor trauma, or patients who have chronic steroid use, and osteoporosis. These are things that are going to clue you in on potentially a fracture. And again, if a patient has a history of like IV drug abuse, if they have fevers with rigors, if they're on any dialysis or any other sort of immunosuppression, you think maybe like some sort of abscess or epidural abscess. And a good physical exam is also good. Doing a full neuro exam, although annoying, it's important so that you can see if there's any sensory deficits. And in any sense, if you're suspecting compression, you want to test rectal tone. You don't test rectal tone on just every musculoskeletal pain, but if you're considering compression, rectal laxity is a sign that you may want to get an MRI. So some must not miss diagnoses. We talked in length about compression syndromes, but aortic emergencies are another one that can present with low back pain. By aortic emergencies, I mean dissection, rupture, penetrating aortic ulcers from patients that have atherosclerotic disease. This is going to be a little bit different. They're usually going to be hemodynamically unstable with a really high mechanism of injury. We talked about malignancy. For fractures, you want to consider the risk factors for fractures, osteoporosis, chronic steroid use, et cetera. And also the mechanism of injury. If you have a mechanism of injury that's so strong to have created a lumbar fracture, you want to look for other injuries as well. Things like pelvic fractures can disrupt the sacral spine and then lead to a compression of the spinal cord and Cauda-Equina syndrome. Infections are important also not to miss. And other general diagnoses, disc herniation, typically when we think of sciatica pain, this is L5-S1 disc herniation, and you can test that with the straight leg test. Other things like spinal stenosis, ankylosing spondylitis, pancreatitis, renal infarcts, all shouldn't be missed either. So when to use imaging, typically it's very limited utility when we're using it for routine back pain. It's associated with increased healthcare costs as well as increased invasive procedures. But if you are suspecting pain with neurologic deficits, you want to pursue an MRI. MRI is the gold standard compared with CT scan. And it's an increased sensitivity and specificity for detecting things like compression, infection, and different cancers. You can also consider ultrasound if you're suspecting compression, ultrasound for post-void residual. If it's more than 500 milliliters in the bladder, then you want to consider Cauda-Equina and get an MRI. So the management we're just going to be discussing uncomplicated low back pain, not the compression syndromes. So the management of uncomplicated pain, first line is going to be oral NSAIDs. You can use topical, however, topical, it's shown to be a same effectiveness with less adverse effects compared to oral NSAIDs, plus or minus muscle relaxants. And I'll talk a little bit on the next slide about the evidence behind this. Lidocaine patches as well had some good evidence to support its use. Back pain education is important, teaching patients how to self-care, which means applying heat, encouraging activity and not bed rest. Is a good thing to do. In terms of using opioids for pain, these are more big gun pain management, especially the patients coming in with like 10 out of 10 back pain. We only use these for severe to moderate, and you wouldn't prescribe anything more than a week if you're discharging the patient. But interestingly, it has been associated with higher 30-day ER returns and increased return to work times. So kind of showing you it's not really, although you can get them out of pain, it's not really effective at managing pain in the ER. So just to discuss some of the studies regarding NSAIDs, there was a Cochrane review that did support its use that showed that NSAIDs are effective for short-term symptom relief in low back pain without sciatica. The effect size was small and there was no NSAID that was superior, but it did also discuss using COX-2 inhibitors having less side effects than traditional NSAIDs. And again, using diclofenac gel as a topical NSAID, and it was shown to be no more effective than oral NSAIDs, but also effective if you're concerned about like a GI bleed or other adverse effects. Another Cochrane review looked at using muscle relaxants, which it did support its use. However, there's a lot of risk versus benefits you want to consider. There's a lot of adverse effects with muscle relaxants, and its use is still underway of being, is it debatable if the risks are better than the benefits? So right now they're not really used routinely in the ER. And then another study looked at, well, what if you combine NSAIDs and muscle relaxants? And it did show that there was a support in the combination of two did provide relief for patients in the acute setting. But again, you want to weigh the risks of the benefits of using a muscle relaxant versus not, and if they're really overall better than just using NSAIDs alone. Some other medications, Tylenol is a favorite for using for pain control, but Tylenol showed that it was no better than placebo in the management of back pain. The studies were really low quality. Actually, they only studied it in some of them for like 5 weeks maximum with like a sample size of less than 70. So there's still research to be done, but there's nothing promising as of now. Topicals we discussed, lidocaine patches did show some good support in acute low back pain. There was no evidence to support the use of gabapentin, antidepressants, or steroids, at least in the short term. And again, with opioids, there's very little evidence looking at opioids on their own. And most of the studies actually didn't even look at the issue of addiction. So that opens up a whole other can of worms of just routinely giving patients opioids for back pain if they're just going to come back with the same back pain. Are you really managing it, or are you just treating their pain? In addition, you can use non-pharmacologic methods, things like physical therapy. And by this, it's a broad term, but by this we mean exercise, neurostimulation, laser massage, etc., applying heat. Interestingly, heat application, that's the first thing we do is give patients heat packs. There was a Cochrane review that looked at 9 trials, over 1,000 patients, that did show that heat decreases acute pain. So there's evidence behind using hot packs. Activity, there was a Cochrane review again that looked at activity in reducing pain recurrences, not necessarily treating the acute pain, but just in reducing the episodes. Patients that come in with low back pain are going to typically have this repeating again. And back schools is just a form of intensive patient education about how to stretch their back and so forth. So to summarize, back pain is one of the most common ER complaints. Over 95% are specific and resolve after some time. Things that you can't miss: compression syndromes, aortic emergencies, infections, neoplasms. If you're going to get imaging, MRI is better than CT scans, and NSAIDs are really the leading standard for treatment. Any questions?